Welcome back to the Deep Dive. Today, we are confronting something that is visually impossible to ignore. It is one of those classic tropes of medicine, usually reserved for cartoons or old movies. But when it happens in real life, it really stops you in your tracks.
It certainly does. I mean, it's a signal you can spot from across the room. It's undeniable.
We are talking about the color yellow, specifically when the human body decides to, change its entire color palette from whatever natural tone it is to a stark, undeniable, almost highlighter yellow. We're talking about jaundice. And this is the key thing. We aren't talking about newborn babies under blue lights, and we aren't talking about, say, liver failure from a lifetime of alcohol. We are talking about a plumbing disaster.
That is exactly the right metaphor. It is a plumbing disaster of the highest order, a complete and total blockage.
We are digging into obstructive jaundice. And I have to say, looking at the research you brought in today, this feels less like a biology lesson and, I don't know, more like a noir detective novel.
I like that.
You have a body. You have a really bizarre visual clue, and you have this ticking clock in the background.
That's why this topic is so high yield, not just for medical students preparing for their boards, but really for anyone who wants to understand how the body signals distress. Obstructive jaundice forces you to think like a detective. You have this very obvious clue, the yellow skin. But the culprit, the cause of it all, is hidden deep inside. It requires anatomical localization, rapid differentiation, and critically, knowing when to act fast.
So you can't just wait and see with this one?
Absolutely not. Unlike some medical mysteries where you can kind of watch and wait, a blocked pipe in the human body is an emergency waiting to happen.
Okay, so let's set the stage for everyone listening. We've got a person who looks in the mirror and sees that Simpson-esque tint. Or maybe they notice their eyes first. The whites of the eyes, the sclera, turning this sort of muddy yellow. What is actually happening? Give us the elevator pitch definition of obstructive jaundice.
Okay. So, if we strip away all the jargon for a second, obstructive jaundice is exactly what it sounds like. It is jaundice caused specifically by a physical blockage to the flow of bile.
A physical blockage, like a dam in a river.
Precisely. But here is the key distinction that separates this from other types of liver issues. The blockage is distal to the liver.
Distal to the liver, so downstream from it.
Exactly, downstream. Think of the liver as a massive, incredibly efficient chemical factory. In obstructive jaundice, the factory itself is actually working fine, at least initially.
The machines are running.
The machinery is humming, the workers are shifting gears, the product is being made, it's doing its job, it's processing waste, it's creating bile. But that bile, once it's made, it hits a wall. It cannot exit the factory gates to get into the intestine where it belongs.
So the factory is running at full capacity, but the delivery trucks are all piled up at the exit gate, and the security guard isn't letting anyone through.
That's a perfect analogy. And because the trucks can't leave, the bile starts piling up on the factory floor until it spills out the windows. In the body, spilling out the windows means leaking back into the bloodstream.
And that's what makes you turn yellow.
That's what makes you turn yellow. And it leads to a very specific chemical profile in the blood called conjugated hyperbilirubinemia.
Okay, let's unpack that term. Conjugated hyperbilirubinemia. That is a mouthful, and frankly, it sounds a bit terrifying.
It is, but it tells you the whole story if you break it down. Bilirubin is essentially a waste product. It comes from breaking down old red blood cells.
Right.
When red blood cells die, they release hemoglobin, which gets broken down into this yellow pigment called bilirubin. Now, when it first arrives at the liver, it's in a state we call unconjugated.
What does unconjugated mean in a practical sense? Is it dangerous?
Think of unconjugated bilirubin as raw, toxic waste.
Wow.
It's oil-soluble, not water-soluble. It's sticky. You can't just dump it into the river, which is your blood or urine, because it won't dissolve.
Right.
It's actually quite dangerous to the brain if it builds up.
So the liver has to treat it first.
Right. The liver is the hazmat team. It takes this raw, toxic waste and puts a chemical hazmat suit on it. That process is called conjugation.
Conjugation.
This little chemical suit makes the bilirubin water-soluble. It makes it safe to travel and, crucially, safe to be excreted into the gut.
I love that image. So if you have high conjugated bilirubin in the blood, it means the liver did its job.
Yeah.
It put the hazmat suit on the waste.
Yes. That is the single most important takeaway. It did the work, it processed the waste, but because the pipe is blocked, that processed water-soluble waste has nowhere to go but back into the bloodstream.
Ah, I see.
That is the absolute hallmark of obstruction. If the liver itself had failed to do its job, you'd have high unconjugated bilirubin, the raw waste would be building up. But here, the factory works. The plumbing is broken.
And strictly speaking, where is this blockage happening? I know we say bile ducts, but can you help us visualize the map here?
Sure. So imagine the liver as this dense forest, and inside that forest are thousands of tiny streams. Those are the intrahepatic ducts.
Okay.
These tiny streams all merge into larger and larger rivers, and eventually they all flow into one main river called the common bile duct. This main river flows out of the liver, runs past the pancreas, and then empties into the ocean, which is your small intestine.
So the blockage can be a dam anywhere on that river system.
It can be. It can be in the tiny streams inside the liver, that's intrahepatic, or much more commonly on that big main river, the extrahepatic bile ducts. But the result is always the same. The flow stops.
So our mission for this deep dive is clear. We have a blockage, we have a yellow patient, we need to figure out how to spot it, how to find the culprit, because it could be a stone, it could be something much worse, and we need to understand why the presence or absence of pain changes the entire diagnosis.
That distinction, pain versus painless, is going to be the absolute pivot point of our entire discussion. It's the difference between a bad Tuesday and a life-altering diagnosis.
Let's get into the detective work then. Section 1. The first clues. Obviously, we have the yellow skin, but the source material points out some other visuals that are, frankly, a little gross, but biochemically fascinating. We have to talk about bathroom habits.
We absolutely have to talk about bathroom habits. It's one of the first things a doctor will ask you. It's that important.
I figured as much.
In obstructive jaundice, the body gives you two very specific, very contrasting signals in the bathroom. The source calls it the exam rule, and it is ironclad. Pale stools plus dark urine equals obstructive jaundice until proven otherwise.
Pale stools and dark urine, that seems almost contradictory. Why does one get lighter and the other get darker? It feels like it should be the other way around.
It's a great question, and it's all about where the dye is going. Normally, bile flows into your intestines. Bile contains bilirubin, and when that hits the bacteria in your gut, it gets converted into a chemical called stercobilin.
Stercobilin.
Stercobilin is brown. It is literally the pigment that dyes your stool brown.
Wait, so the reason poop is brown is essentially from old, processed red blood cells. It's like rust.
In a way, yes. It's the final breakdown product of blood. It's the body's own personal paint job. It's fascinating, isn't it?
That's incredible. So if the pipe is blocked,
no dye reaches the intestine. Simple as that. The stool loses its pigment completely. It becomes clay-colored or putty-colored. Sometimes it's described as looking like window putty. It's pale, almost ghostly.
okay, so that explains the pale stool. The dye is missing because the delivery truck didn't arrive. But why does the urine go dark?
Because that bile, that dye, has to go somewhere. It backs up from the liver into the bloodstream. Now remember our hazmat suit analogy. This is conjugated bilirubin.
The water-soluble kind.
The water-soluble kind, exactly. Because it dissolves in water, the kidneys can filter it out of the blood.
Ah, I see where this is going now.
The kidneys act as an emergency relief valve. They see all this pigment in the blood, and they start dumping this excess yellow-brown pigment into the urine. But because it's so concentrated, it doesn't look yellow. It turns the urine dark like strong tea or flat Coca-Cola.
That is a fascinating bit of plumbing mechanics. The brown pigment is diverted from the back door to the front door, essentially.
That's a great way to put it. And noticing that combination, Doc, my poop looks like clay and my pee looks like Coke, is often the very first sign, sometimes even before the skin turns noticeably yellow.
The source also mentioned something called pruritus, which is the fancy medical word for itching, right?
Right. And we need to be clear, this isn't just a mild tickle. This is a deep, maddening, under-the-skin itch that can drive people absolutely crazy.
So why does a black liver pipe make you itch? Is it the bilirubin itself?
That's what people often think, but it's actually likely the bile salts. Bile contains salts that act like soup to help break down fat in your food.
Okay.
When the bile backs up, those salts deposit in the dermis, the deep layer of the skin. They directly irritate the free nerve endings there. It's a chemical irritation.
So it's not an allergy. It's more like a chemical burn from the inside out.
That's a good way to think of it. You will often see patients with obstructive jaundice who have visible linear scratch marks, we call them excoriations, all over their arms and chest because they just cannot get relief. They'll use hairbrushes, anything. And antihistamines like Benadryl usually don't work because it's not a histamine reaction. It's a direct chemical assault on the nerves.
So we have a patient who is yellow, scratching their skin raw,
Mm-hmm.
has tea-colored urine, and clay-colored stool.
Yeah.
They are a walking billboard for blockage.
They really are. And on top of that, you might see some general symptoms, loss of appetite, maybe some weight loss, which are just general signs of being unwell. But those specific 4 symptoms, yellow skin, the itch, pale stool, dark urine, that is your dashboard warning light screaming, check engine now.
Okay, so the warning light is flashing. We know we have a blockage. Now we come to what you said is the most critical part of this deep dive, the fork in the road.
This is it. This is the moment where the doctor has to make a binary decision that changes absolutely everything. Is the jaundice painful or is it painless?
The source calls this the most high-yield concept. Why is this one distinction so vital?
Because it splits your list of possible causes, your suspects, into 2 completely different categories. It determines the urgency, the type of investigation, the treatment, and frankly, the likely prognosis. It's the difference between a mechanic fixing a flat tire and telling you the engine block is cracked.
That's a serious distinction. Okay, let's go down path A first. Painful jaundice. Let's create a character here to make it real. Let's say Arthur. Arthur is 45, maybe he likes his fried food. He wakes up yellow, but he is also absolutely miserable.
Right. Arthur is in distress. Painful jaundice typically presents with something called biliary colic. It's the severe pain in the right upper quadrant of the abdomen.
So right under the rib cage on the right side.
Exactly. And the word colicky is key. It's a word doctors love, but what it means to Arthur is that it's not a constant ache. It comes in waves.
Waves.
It's an intense, gripping, visceral pain that builds to a peak and then subsides, and then it builds again. It's the same mechanism as labor pains or a kidney stone passing.
So why does it happen in waves? What's causing that?
Because the bile duct is a tube made of smooth muscle. If there is a blockage, that muscle tries to overcome it. It squeezes violently to try and push the fluid past the block. That powerful squeeze is the colic. And with Arthur, you might also see a fever, because where there is blockage and stagnation, there is often infection.
So if Arthur is hurting and he's yellow, what is the usual culprit? What's blocking his pipe?
Usually, it is something benign. The most common cause of painful jaundice, by far, is choledocholitis.
That is a fantastic word. Choledocholitis.
Yeah.
I feel smarter just saying it.
It sounds incredibly complex, but if you just break it down. Choledocha refers to the common bile duct, that main river. Lithiasis just means stone. It's a stone stuck in the main bile pipe.
So it's basically a kidney stone situation, but in the liver plumbing.
That is the perfect analogy. It hurts for the exact same reason a kidney stone hurts. The body is trying to squeeze a hard, unyielding rock through a soft, narrow tube. The duct spasms around the stone, and that's what causes that colicky, wave-like pain.
So paradoxically, pain is actually good news here. I mean, relatively speaking, of course.
Relatively speaking, yes. Pain usually implies a stone, and stones, while incredibly painful, can be removed. It's a mechanical problem, a plumbing clog, but it's usually not a life-threatening malignancy.
Which brings us to path B, painless jaundice. Let's introduce another character, maybe Sarah. Sarah is 65. She notices she's turning a bit yellow, or maybe her husband points it out, but she feels fine.
Maybe a little tired. Maybe her clothes are fitting a bit looser than they used to, but no pain, no gripping cramps, no doubling over in agony.
This sounds like it should be the better option.
Yeah.
Hey, I'm turning yellow, but at least I'm not in terrible pain.
And that is the trap. That is the single most dangerous assumption a patient or a doctor can make. The source emphasizes this so heavily. Painless progressive jaundice is carcinoma until proven otherwise.
Wow. So the absence of pain is the real red flag.
It is the reddest of flags. In Sarah's scenario, there is no colic. There is no violent spasm. There's just a slow, progressive deepening of the yellow color. The patient gets yellower and yellower over weeks, often without noticing it at first because they don't feel sick in that acute, painful sense.
And what is the suspect here? What's causing this silent blockage?
The most common malignant cause, the #1 suspect, is carcinoma of the head of the pancreas.
Why the head of the pancreas specifically? Why not the tail or the body of the pancreas?
It's all about anatomy. It's a real estate problem. The pancreas is shaped sort of like a tadpole lying across the back of the abdomen. The head is the thick part, and it's tucked right into the curve of the intestine. And crucially, the common bile duct, that main river we talked about, runs right through or immediately behind the head of the pancreas on its way to the intestine.
Oh, so it tunnels right through it.
Exactly. So if a tumor starts growing in the head of the pancreas, it slowly expands. It doesn't burst or cause a sudden problem. It just impinges on that duct. It silently squeezes that duct shut. It's like someone very, very slowly stepping on a garden hose over the course of weeks.
It's a slow strangulation rather than a sudden blockage with a rock.
Yes. And because it's slow growth, the duct doesn't spasm. The body sort of accommodates the rising pressure slowly. And that's why there's no pain, just silence and jaundice.
That is terrifyingly counterintuitive. No pain is actually the worst sign.
It is. And that's why we teach this so aggressively in medical school. If a patient walks in looking yellow and says, "Doc, I feel fine, just a bit itchy," your internal alarm bells should be ringing much, much louder than if they came in screaming in pain.
So we've split the cases. Painful usually equals stones, our friend Arthur. Painless usually equals cancer, our friend Sarah. Let's look at the suspect list in a bit more detail. We've mentioned the main ones, but who else is in the lineup?
Well, under the benign category, besides stones in the common bile duct, which again is the #1 cause overall, you can also have benign biliary strictures.
Strictures, what's that?
Think of a stricture as a scar. Maybe the patient had their gallbladder out 10 years ago and there was some scarring from the surgery, or they have chronic inflammation. The duct heals with scar tissue, and that scar tissue tightens over time, narrowing the pipe like an hourglass. You can also see this in chronic pancreatitis, where the pancreas itself becomes scarred and hard, and it compresses the duct from the outside.
And on the malignant side, we have pancreatic cancer as the big one. Who else is on that list?
So we also have cholangiocarcinoma.
Which is?
That's a cancer that arises from the cells lining the bile ducts themselves. It's a cancer of the plumbing, not of a neighboring organ. Then there's periampullary carcinoma, which is a cancer right at the spot where the duct enters the intestine. That little opening is called the ampulla. And lastly, you can have gallbladder carcinoma that has grown to invade the duct.
It's a nasty list of characters.
It is. But remember the rule of thumb for anyone listening. Gallstones are the #1 cause overall. Pancreatic cancer is the #1 malignant cause. If you're betting, those are the 2 horses to bet on.
Now, you can't always just look at a patient or ask them about pain. Sometimes you have to physically feel for clues. And the source brings up a really classic physical exam finding called Courvoisier's sign.
Yes, this is a classic medical pearl. It's a logic puzzle that often trips people up because it seems to go against common sense.
What are we looking for with our hands here?
Yeah.
What are we feeling for?
You are palpating the right upper abdomen, gently feeling for the gallbladder. Normally, you can't feel a healthy gallbladder. It's soft and it's tucked way up under the liver. Courvoisier's sign is defined as a palpable, non-tender gallbladder in a jaundiced patient.
So you can feel the gallbladder. It feels like a little water balloon maybe, but it doesn't hurt when you press on it.
Correct. And the implication is, if you find this, it strongly suggests malignant obstruction.
Wait, hold on. That sounds completely backward to me. If I have a giant swollen gallbladder, wouldn't that mean it's clogged with stones? I'd assume a stone blockage would back everything up and blow the gallbladder up like a balloon. That just feels logical.
And that is the logical trap. That is exactly why Courvoisier's sign is so famous and so important. Here is the physiology behind it. If a patient has gallstones that are now causing an obstruction in the main duct, they haven't just had those stones for a week. They've usually had them for years. Chronic stones cause chronic inflammation.
Okay, so the gallbladder has been beaten up over time by these stones.
Exactly. It's been through a war. It becomes fibrotic. It scars down. It shrinks. It becomes thick and leathery. It is physically incapable of stretching. So even if a stone gets out and blocks the main duct downstream, that shrunken, battle-scarred, stone-diseased gallbladder cannot balloon up. It stays small and hidden under the ribs.
I see. So a shrunken, scarred gallbladder is actually the sign of long-term stone disease.
Right. Now contrast that with the cancer patient, with Sarah. If the blockage is from a tumor, say pancreatic cancer, that blockage is relatively new in the grand scheme of things. Before the tumor started growing, her gallbladder was probably perfectly healthy. It was elastic, it was soft.
It hasn't been scarred down by years and years of stones rattling around inside it.
Exactly. So as the bile backs up behind that slow-growing tumor, that healthy elastic gallbladder just fills up, it distends, it balloons out, it becomes big enough that you can feel it. And because it's not inflamed, it's just full like a water balloon.
Yeah.
It doesn't hurt when you press on it.
That is a brilliant piece of deduction. So palpable, non-tender gallbladder equals cancer, because a gallbladder that's used to stones would be too scarred and tough to stretch.
You've got it. That is the why behind the rule. It's all about the history of the organ's elasticity. It's a beautiful clinical sign.
Okay, we've taken the history, we've checked the color of the stool, we've felt the belly, and we've either found or not found the gallbladder. Now we need to confirm our suspicions. We need to bring in the toolkit.
The investigations. And the source really emphasizes a stepwise approach. This is crucial. In modern medicine, it's so tempting to just put everyone in the donut of truth, the CT scanner. But you have to be logical, and you have to be cost-effective.
So step one is the blood work, the liver function tests, or LFTs.
Right. First, we need to prove on paper that this is actually obstructive. So we are looking for that raised conjugated bilirubin that we talked about. But there's another enzyme we look for that really clinches it, ALP, or alkaline phosphatase.
What does ALP tell us that bilirubin doesn't?
ALP is an enzyme that's found in the cells lining the bile ducts. When those ducts are under pressure, when they are blocked and stretching, the cells lining the duct get irritated, and they leak ALP into the blood like crazy. So a markedly raised ALP is the duct itself shouting, "I'm under pressure, help!" It is a very specific marker for biliary obstruction.
Okay, so the blood work confirms our suspicion of obstruction. Now we need to see it. What is our first-line camera?
Ultrasound of the abdomen. Always, always, always start with the ultrasound.
Why not jump straight to the high-tech CT scan? Isn't it more detailed? Isn't it just a better picture?
It is more detailed for some things, but ultrasound has superpowers when it comes to fluids and stones. It's non-invasive, it's cheap, there's no radiation, and surprisingly, it is actually better at seeing gallstones than a CT scan.
Really? Why is that?
Stones can sometimes be invisible on CT because they have the same density as the fluid around them, but on ultrasound, they're very dense and they cast a shadow. They light up like little stars with a dark trail behind them. It's very clear.
So the cheap, old-school ultrasound is actually better for the #1 cause.
It is. Plus, ultrasound is great at telling you if the ducts are dilated. It can measure the width of the pipe with a caliper. If the main pipe is wide, like a swollen river, you know for sure there's a blockage downstream somewhere.
So ultrasound is great at finding stones and dilation.
Yeah.
When do we bring in the CT?
Step 3. If the ultrasound shows dilated ducts but no stones, now your alarm bells are ringing for a tumor. The ultrasound isn't great at looking at the pancreas deeply because gas in the stomach often blocks the view, so that's when you get the CT scan. It's for staging, it helps you find the mass, see how big it is, and critically, see if it has spread to other organs or blood vessels.
Okay, and the source mentions two acronyms that sound very similar and can be confusing, MRCP and ERCP. Let's distinguish these because they sound identical but do very, very different things. Let's start with MRCP.
MRCP stands for Magnetic Resonance Cholangiopancreatography. It's a mouthful.
It is.
Think of it as an MRI that is focused specifically on the plumbing. It uses the body's own fluid, the bile, as a contrast agent. It gives you this beautiful, detailed 3D map of the entire biliary tree. But here's the key. It is purely diagnostic. You are just looking. You are taking a picture. It's non-invasive.
Okay, so MRCP is the architect's blueprint of the plumbing system.
Yeah.
Then what is ERCP?
ERCP, endoscopic retrograde cholangiopancreatography, is the heavy hitter. This is not just a scan. This is an invasive procedure.
So describe what's happening in the room during an ERCP.
The patient is sedated. You take a special kind of endoscope, a long, flexible tube with a camera, and you put it down the throat, through the stomach, and into the start of the small intestine. But here's the trick. The camera is on the side of the scope, not the front.
Why on the side?
Because the opening of the bile duct is on the side wall of the intestine, so you have to park the scope next to it and look sideways to find it. Then you insert tiny wires and catheters up into the bile duct. That's the retrograde part. You are going against a normal flow of bile.
That sounds incredibly delicate and high skill.
It's like video game surgery. It requires immense skill. But the absolute beauty of ERCP is that it is both diagnostic and therapeutic. If you inject dye and you see a stone on the X-ray, you can reach in with a tiny wire basket or a balloon and pull it out right then and there.
So you don't use ERCP just to take a look around?
Never. You never do an ERCP just for diagnosis. It carries serious risks. Because you are messing with the pancreas opening, you can accidentally cause acute pancreatitis, which can be devastating. You can cause bleeding. You can punch a hole in the intestine. It is not a screening tool. You only use it when you have a very strong suspicion of a problem that you intend to fix at the same time.
We've identified the problem. We know how to find it. But what if we don't? What happens if Arthur or Sarah just ignores this yellow warning light? We enter what the outline calls the danger zone.
This is the so what factor. Why is a blocked pipe dangerous? It's not just because you turn yellow. I mean, yellow is cosmetic. The real danger is infection and systemic failure.
The source mentions ascending cholangitis. This sounds like the boss battle of this entire condition.
It is a true medical emergency. Imagine a stagnant pond. If water stops flowing, algae and bacteria grow. In the body, the bile is stagnant because of the block. So bacteria from the gut E. coli, Klebsiella, they literally swim up the duct from the intestine.
Ascending, that's where the name comes from.
Yes. They ascend against the non-existent flow, and they infect that stagnant pool of bile. So now, instead of sterile bile in your liver, you effectively have a pressurized abscess, pus under pressure, inside your liver plumbing. This is ascending cholangitis. The bacteria can then rapidly enter the bloodstream, causing life-threatening sepsis.
And how does that look in a patient? How do they present?
They present with what's called Charcot's triad. This is another one of those classic exam staples. It's fever plus jaundice plus right upper quadrant pain. If you see those three together, you have to assume the patient is septic from cholangitis. They are often shaking uncontrollably. Their blood pressure is dropping. They need their ducts decompressed immediately or they will die.
So the infection is one huge danger. But the source also mentions something about blood clotting. Coagulopathy. This felt like a bizarre Rube Goldberg machine of failure.
It really is. It's a fascinating domino effect. Let's trace it back. To clot your blood properly, your liver needs to produce a bunch of proteins we call clotting factors.
Okay.
To make those factors, the liver needs a key raw ingredient, vitamin K.
Okay. Vitamin K is the raw material for the clotting factory.
Right. But here's the catch. Vitamin K is a fat-soluble vitamin. It's like vitamin A, D, and E. It dissolves in fat, not water. And to absorb fat from your food, you need bile. Bile is the soap that your body uses to emulsify the fat so you can absorb it.
I think I see the chain reaction building here.
No bile flow into the intestine means no soap. No soap means you can't digest fat. It just slides right through you. And if you can't digest and absorb the fat from your diet, you can't absorb the vitamin K that's dissolved in it.
So the vitamin K just slides out with the fat.
Exactly. So your vitamin K levels in your body start to tank. And without vitamin K, the liver's 3D printer for clotting factors runs out of ink. It just stops working.
And the result is the patient's blood won't clot. They bleed.
The patient's blood becomes incredibly thin. They are prone to spontaneous bleeding, bruising everywhere. And this is critically important because usually the treatment for obstructive jaundice involves an invasive procedure or a major surgery.
Right.
If you try to operate on a patient who can't clot, you are creating an absolute disaster. They will bleed out on the table.
That is a massive trap for a doctor. You want to rush in and fix the block, but if you don't fix the blood first, you could kill the patient.
Precisely. It's an exam trap for a reason. You essentially have to correct the vitamin K deficiency often by giving injections of vitamin K directly into the muscle or blood and wait for the clotting to normalize before you touch them with a scalpel or a scope.
So we cannot ignore the yellow light. We have to fix it.
Oh, what?
Let's talk about that.
Well,
Section 6. The fix. How do we get the plumbing working again?
the management plan really relies on three main pillars. First, you resuscitate. If they have cholangitis, you blast them with IV antibiotics and fluids. Second, you correct the clotting. You give that vitamin K we just talked about. And third, and most importantly, you have to relieve the obstruction. You have to get the bile flowing.
And the method for doing that depends entirely on the cause.
Right, totally. If it's benign, if it's Arthur with his gallstone, the gold standard is that ERCP we talked about. You go in with the scope, you can make a tiny cut at the opening of the duct to widen it. That's called a sphincterotomy. And then you drag the stone out with a little wire basket. Problem solved. The flow is restored immediately.
And if that fails for some reason?
And you might need a formal surgical exploration where a surgeon opens up the duct to remove the stone. But ERCP clears the vast majority of stones these days. It's incredibly effective.
Now, what about Sarah? The tougher cases. Malignancy.
This is obviously much more complex and somber. The first step is to stage the cancer properly with scans. If the tumor is deemed resectable, meaning it hasn't spread to distant organs or encased major blood vessels, then the goal is a curative surgery. For pancreatic head cancer, that's usually the Whipple procedure.
I've heard of the Whipple. It's supposed to be one of the biggest, most complicated surgeries a human can undergo.
It is a massive operation. You are removing the head of the pancreas, the gallbladder, part of the stomach, the first part of the intestine, and the bile duct, and then replumbing everything back together. It's a huge undertaking with a long recovery.
But sadly, a lot of these are caught late, right? Precisely because they are painless.
Yes. That is the fundamental tragedy of the silent jaundice. Often, by the time sera turns yellow, the tumor has already wrapped itself around major arteries or has spread to the liver. It's deemed unresectable.
So if we can't cure the cancer, what do we do? Do we just leave them yellow and itchy for the rest of their lives?
No, absolutely not. The goal of treatment changes from cure to palliation. We want to improve the quality of life. The itching is torture. The jaundice makes them feel terribly ill. So we use that ERCP scope again.
To do what? If you can't take the tumor out?
To place a stent, we can slide a small plastic or metal mesh tube right through the middle of the tumor, through the blocked area of the duct. We essentially force the duct open from the inside.
So you're propping open a collapsing tunnel.
That's a perfect description. It doesn't remove the tumor, but it reestablishes the plumbing. The bile can flow again, the jaundice clears up, the itching stops, the patient gets their color back and feels significantly better for the time they have left.
It restores the flow.
At the end of the day, it's all about restoring the flow. In obstructive jaundice, flow is life.
We have covered a massive amount of ground here. We've gone from the color of skin to the intricate biochemistry of vitamin K and the high-stakes video game surgery of ERCP. Let's do a rapid-fire recap to really lock this in. The source lists 10 top takeaways. I'm going to throw the concepts at you. You give me the punchline.
Let's do it. I'm ready.
Concept 1, the definition. What is this, fundamentally?
It's an obstruction to bile flow distal to the liver. And it always results in conjugated hyperbilirubinemia.
Concept 2, the key visual.
Tail stools and dark urine. The dye is in the wrong place.
Concept 3, the big fork in the road.
Painful versus painless. That's the question that changes everything.
Concept 4, what does painful usually mean?
Stones, biliary colic, and thankfully, usually benign.
Concept 5, what does painless usually mean?
This is the scary one. Malignancy. Think cancer of the pancreatic head. It's the silent threat.
Concept 6, the physical exam logic trap.
Courvoisier sign. A palpable, non-tender gallbladder suggests cancer, not stones, because the chronic inflammation from stones makes a gallbladder too scarred and small to stretch.
Concept 7, first test you should always order.
Ultrasound of the abdomen. It's the best first step for seeing stones and duct dilation.
Concept 8, the role of ERCP. When do you use it?
It is both diagnostic and therapeutic. You use it to pull stones or place stents. It is not for screening.
Concept 9, the true emergency.
Ascending cholangitis. That's pus under pressure in the liver. Look for Charcot's triad: fever, jaundice, and pain.
Concept 10, the pre-op trap to avoid.
Coagulopathy. No bile in the gut means no vitamin K absorption. Never, ever operate without correcting the clotting first.
And that brings us to our final thought for today.
You know what strikes me most about this entire deep dive is how the body speaks to us. It doesn't use words, obviously. It uses this language of colors: yellow skin, brown urine, white stool. It uses sensations, that wave of colic, the maddening itch. And sometimes, and this is the most dangerous part, it uses silence, the painless jaundice.
It really is language, isn't it? And you have to learn the grammar to understand what's being said.
Exactly. The art of medicine, and really the art of being well informed about your own health, is learning to interpret these patterns correctly. We are all programmed to think that pain is the ultimate warning sign. We think pain equals bad. But in obstructive jaundice, we learned that the noisy, screaming, painful stone is actually the better problem to have. It demands attention. It screams for help.
Whereas the silent shift in color.
That's the one that hides the true threat. The body is a pattern recognition machine. The question that this all leaves me with is, are we listening close enough to distinguish the painful warning from the deadly silence?
Something to think about next time you look in the mirror. That wraps up our deep dive on obstructive jaundice. Thanks for plumbing the depths with us.
My pleasure. It was a great conversation.
See you on the next deep dive.